My name is Santiago Gonzalez-Moreno. I am a surgical oncologist. I am the president of the European and the Spanish Society of Surgical Oncology. I am medical director and head of surgical oncology at MD Anderson Cancer Center in Madrid, Spain. And I am also adjunct professor of surgical oncology at MD Anderson Cancer Center in Texas. Oftentimes, surgical oncologists, who are the surgeons who are specialized in cancer, knowledge and treatment of cancer, are oftentimes the leaders and the coordinators of multidisciplinary teams. Surgery has a central role in oncology, a central role in the management of cancer patients. We use surgery from the very beginning of the disease and all throughout the natural history of the disease. We oftentimes need surgery to get a biopsy, and without a biopsy, we cannot have a diagnosis. So we say tissue is the issue. Tissue is important to get a diagnosis, and without a diagnosis, we cannot start treating a patient. So from diagnosis to curative intent treatment, surgery is important and maybe the most important treatment modality in cancer. Without surgery, there is no cure. So surgery is central to diagnosis, is maybe the most significant contributor to curative intent treatment, although certainly it should be complemented by other modalities like radiation treatment and systemic chemotherapy, or other modalities of treatment today like immunotherapy or biological therapy. And certainly surgery plays a role also in the palliative management of cancer patients. This is sometimes overlooked. But surgery can provide significant palliation to patients when we cannot cure them. Absolutely. I mean, multidisciplinarity is central to the treatment and to every single aspect of cancer and of oncology. Cancer is a disease with many different phases. If you look down into the biology of cancer, there are so many publications every single day about new breakthroughs in biology, new breakthroughs in how we learn what cancer is about. It's impossible to tackle all of them with only one treatment modality. Whoever wants to do it on its own will actually fail in treating or in succeeding in treating cancer patients. Well, multidisciplinary teams have been implemented and implanted progressively all over Europe. I am myself from Spain. This was certainly a dream back 10 years ago, and right now I can say that most hospitals, at least most tertiary level hospitals, do have multidisciplinary teams. So it's been a matter of time to get it implemented. There are some hinders that have to do with I would say logistics in the hospital and with coordinating different schedules and different things about the different specialties, but that is something that can be overcome very easily. There can be also some, I would say, logistic issues having to do with the spaces. For me, the best multidisciplinary clinic we can have is a clinic where the radiation, the medical and the surgical oncologists can look at the patient together. For that, you need spacious rooms that sometimes you cannot have. So there's maybe some, some component to having the appropriate space and an environment for it. And that should be the only hinder today towards multidisciplinarity in a tertiary level hospital. Because there in the past, and I hope that's over now, the hinder was actually that some specialists didn't feel the need to collaborate with each other. It's sad to say that in some places that's still the case, but I would say that that example is actually called to be extinguished very soon, and I would say that that's not the case right now.